agents, in terms of ventilator management, in terms of post-operative period. So this patient, when the patient is coming from from theater, what are your projection? Will this patient be placed on the vent? If the patient is on the vent, high level of oxygenation increase, high level of energy demand because of the FiO2, which can induce high level of catabolism. So you have to factor in all those times so that you are able to well properly calculate your plan. And then early metabolism in terms of facilitate protein synthesis and muscle function. So you must be able to look at early mobilization meant or mobilization in this case where you have to have the physiotherapist on board. What are these patients after the procedure? Would they be able to do some ambulation around so that their circulation can improve? So that when the circulation is improved, they will be able to help in the synthesis of protein and so on. So, yeah, because it's very important. Oxygen is really needed as far as cellular metabolism is concerned. Yeah, so nutritional care protocol for surgical patient must include, you must have been taught all these things, just a summary, detailed nutritional and medical history that include body composition assessment. So in these cases, you are going to assess this patient to find out what was the patient nutritional status before even they had that condition, or what has this patient eaten or protocol been, what is their nutritional practice? Have they been eating well? Were they able to have access to food? And then when you do the assessment, if you have feeds to recommend in terms of oral nutrition supplementation, what is parenteral nutrition, is the patient able to to pay for this? Are they able to afford, or do they have a cover that is able to do so? You have to be able to look into all those things. That's where you are able to come in, and then you can also have a conference with the family of this patient and so on. So you need to have your nutritional intervention plan. How do you develop your nutritional intervention plan? Is when you are doing the assessment to know that this patient after surgery they will be at serious risk of becoming minority. So this is what I have. So caregiver, this is what we want to do, and this is where we are, and this is where we are going. So are you guys able to afford this or that? And then they will be able to tell you their stand. It is based on that stand you are going to formulate your meal plan, and we are going to be looking at whether this patient, what kinds of food this patient should be fed on in terms of or whether it's intravenous in terms of oral and so on. You will be able to see that. But this is it's almost like an assessment stage. So when you assess the patient, you are able to ascertain to know what will be your plan based on your assessment. So, and then an amendment of the intervention plan where appropriate. So, because if you are able to assess this patient and able to understand what the condition of the patient is in terms of affordability, in terms of accessibility, in terms of availability of the feed you want to use for intervention as far as your supplementation is concerned, then it can make you to have some adjustment, whether you can continue with your plan or you can have some adjustment to suit the condition and state of the patient as far as the surgery is concerned, and as far as the patient financial status is concerned. And then you have to be very clear and accurate in your documentation to as far as assessment of the nutrition and clinical outcome would be. So your documentation in this case is you are very sure and say this patient, if we are able to give this patient this amount of calories and we are able to intervene this way, the outcome of the patient will be okay because we are trying to prevent more catabolism so that we are able to maintain strength of the muscles for the muscles to be protected, so the immunity of this patient to be at a good level. So that the patient, if it is wound healing, this patient will have rapid wound healing so that their length of stay in the hospital can be shortened. And then you are able to clearly communicate your plan to the team, and then they are certain that we are going this way because this is the result that we are expecting. And after this result, this is where we will be in the next 3 to 4 days after the procedure to resistant exercise whenever possible. So you are able to talk to the team, and then this one is known actually where you will be able to do it as a nutritionist. This is a team decision, a team playing decision where we say, okay, now that you have this plan for your nutrition, physiotherapy, you come and this is what you will be doing for the patient to be mobilized, and then we are going to achieve what we want to achieve as we carry on our plan as the entire team has one decided and concluded upon. So one thing I want to for you to know and never rule out this is the surgery itself. A patient is going for a surgery, you have no control over it. It is something that even the doctor themselves, there is some unpredictability of the outcome of the surgery. That's why before a patient is going for the surgery, they have to seek the consent of the caregiver of the patient or the patient, depending on the patient's status. If the patient is not able to communicate, the patient is unconscious to make a sound decision, then the relative of the patient, either the immediate spouse, could be the husband or the wife, or the immediate family, could be mother or father, or could be sisters or brother, or could be the children of that patient. But whoever that is there that is of concern in terms of caregiving, uh, to psychologically or financially support this patient, you have to seek their consent. So, in the case of the surgery, the surgeon themselves have some level of limitation. They don't know the outcome of the patient because looking at the state of the patient, that's why in some cases, you the patient relative will be told that we are going in with this patient, or this is what we expect. It is 50-50. The patient might survive it, or the patient might not survive it. Or sometimes we say we cannot go in with this patient if we don't have this amount of unit of blood, or we cannot go in with this patient if we don't have this kind of or organ or being well or attended to for us to know the state of either the state of the heart or the state of the liver or something or the kidney. So there are something that they have to fix before they are able to make sure that they are going in with this patient. So that will tell you that their surgery has its own complication and side effect that is associated with the outcome of this patient that you as a nutritionist you have no control over. So have that to the back of your mind. And what are some of these things that you need to look at to balance the extent of the surgery with the ability of the body to deal with the metabolic load that will be a considerable challenge for the surgeon. So when they are going in for surgery, know that that is a deliberate inflammation that will be induced by the procedure. That means it will be a medically induced systemic inflammatory stress response syndrome, which will be induced just from the surgery alone, that the wound that will be one inflamed. And these things they are associated by high risk of bleeding, high risk of infection, and so on. And even the anesthesia that will be given to the patient, it has its own complication. So all those things should be at the back of your mind. You must know that these are the things that will come. That's why even this patient will be NPO because of the anesthesia. One of the major concerns of this of surgeon and the anesthetist is the issue of patient aspirating when you give them the anesthesia and they have fed. But we are going to look at and we will have a clear information on or what is their position and what should be done and what is not a reality and what actually is a reality. We will see that. So that is one of the things you should also have to the back of your mind. And this refers to relevant comorbidity with special regard to the cardiopulmonary
Jesse,
capacity and therefore, yeah,
we have like around 7 minutes. Eh?
okay.
Okay.
So yeah, so all these issue here, it has to do with the condition that will be induced into the patient and so on. So these are things that you must be able to understand what is going on with the patient because there will be presence of inflammation and all those things. So there are external risks of the surgery which are not tailored to the capacity of the patient to generate an adequate host response and so on. So all these things has negative effect on making sure that this patient will be at risk of high uh, muscle wasting and so on. So there are some basic questions which is this is very important unless you guys will want me to stop. But these are things that I don't know whether you will have covered. But this is something very important and you can really learn from this. This is one of the managerial aspect of a patient going for surgery and that will be coming out. So these questions, if you can answer them, then it's very okay. One of them is operative fasting necessary? This is a question whether you have answered or not. Recommendation is pre-operative fasting from midnight is unnecessary, especially where they will tell you the patient should fast from 12 a.m. to 6 a.m. and the surgery is around 6:30 or 7, or the surgery will be at 9 a.m. and then they tell you the patient should start fasting from 12 a.m. No, it's not necessary. Research has indicated that it's not necessary. The patient can take clear fluid until 2 hours before the anesthesia. Why? Is one of their major concerns had been because the patient might aspirate. But why? Remember, if you look at the digestibility of all of the nutrients in terms of the order of their state of matters, in terms of fluid, which is now liquid, solid, semi-solid, and so on. Fluid digests faster. In the next 30 minutes to 1 hour, they are already in your bloodstream. So this patient can have a fluid, clear fluid diet, like especially for those sometimes they go in for some procedure, we say give them apple juice and all those so because they are quick to be digested. So you can advocate for the patient not to fast for that long, depending on the procedure. So the grade recommended is grade A and is very strong. There's a strong concession of 97% agreement. Commentary: there is no evidence that patients giving clear fluid up to 2 hours before elective or operation are at any greater risk of aspiration or something we call vegetation, which is something like vomiting and so on, or caused by gastric pressure, than those fasted for additional 12 hours or longer. Since clear fluid emptied the stomach within 60 to 90 minutes, like exactly what I was saying, between like 30 minutes to 1 hour, the fluid has already reached your bloodstream. So, is the next question is pre-operative metabolic preparation of the elective patient using carbohydrate treatment useful? Recommendation number two. Now, this is a question. We have something called carbohydrate treatment. Carbohydrate treatment is where the patient is given dextrose or they are given some carbohydrate fluid where they like to boost up the level of energy or the sugar level so that the patient will not become hypo when the process is over and then that long time of fasting after the procedure. So in order to reduce the preoperative discomfort, including anxiety of oral or preoperative carbohydrate treatment, instead of overnight fasting, the night before and 2 hours before the surgery, this carbohydrate therapy should be administered. And the impact of preoperative insulin resistance and hospital length of stay. Preoperative carbohydrate can be considered in patient undergoing major surgery. So the consensus conference is 100% agreement. I mean, everybody that was at that conference, their recommendation is yes, this patient will be given a carbohydrate treatment because of the long term of this major surgery. Commentary on this is what are the measurement, precise administration of this carbohydrate drink. It can give from 800 mils not before or 400 mils before the surgery. Does not increase any risk of aspiration. So 800 mils can be given. That is the night before. That is like overnight where the patient was supposed to be fasting. They can give the 800 ml, or they can give 400 ml like 2 hours before the surgery. That is the carbohydrate load. So if those carbohydrate or fluid are not available, that this or dextrose to be given intravenously or whatever, you can give fruit-based lemonade, which may be considered a safe alternative with no difference in gastric emptying time. So it's very important for you to have this to the back of your mind. Another question is post-operative interruption of oral nutrition intake generally necessary after surgery? Yeah, when you talk about interruption, it's where the patient, where they will be advising this patient not to take anything orally, nil by oral for 72 hours and so on. Can that 72 hour be interrupted like maybe around 48 hours and so on? So what is the recommendation saying? In general, oral nutritional intake should be continued after surgery without interruption. Grade of recommendation is a very strong one and 90% agreement. Because in some cases, it's not everyone that are or able, be able to tolerate it. That's where the 10% is located. So the recommendation for this is the patient can adapt to over intake, and as they tolerate, the patient can continue. If they don't tolerate, you can discontinue. But in 90% of the agreement, based on research that have been taken, it does not really have any contraindication, and I've actually tried this and it works. And then recommendation 5, oral intake including clear liquid should be initiated within hours after surgery in most patients. Grade of recommendation is A, which is a strong consensual 100% agreement. Commentary, oral nutrition, Ballon Hospital diet on oral nutrition supplement can be initiated in most cases immediately after surgery, since neither or also for gastric or decompression nor delay oral intake even after cholecystectomy or colorectal resection have proven beneficiary. So what is happening here is most of the time this restriction coming because of the anesthesia. But if you find out like if it has to do with bowel reception, you find out a part of the intestine, or whether it's small or the big that is infected, they are removed. And when they are removed, the good intestine they are joined. So that joining, it doesn't really affect anything that has to do with absorption. If it is in the colon region, absorption normally takes place in terms of assimilation of the fluid to the system from the small intestine. So it don't have to be it don't have to be prevented because that fluid is not really going to reach to the bowel reception in terms of the colon. So when is nutritional assessment and therapy indicated in the surgical patient? Recommendation says it is recommended to assess the nutritional status before and after surgery. Grade of recommendation is 100%. It is recommended that you assess the nutritional status before and after a major surgery of this patient, so that you will be able to understand the impact of the surgery that it might have had on this patient or after when you did your initial assessment. So pre-operative nutrition therapy is indicated in patients with malnutrition and those that are at nutritional risk. So it's very important for us to know on this. The recommendation rate is 92%. So the influence of nutritional status on pre and post-operative or morbidity and mortality has been documented well in both retrospective and prospective study. So there are a lot of terrible feedback. So an inadequate oral intake for more than 14 days is associated with a higher mortality. So the energy and protein requirement can be estimated with 25 to 30 kilocalories, which will also give you 1.5 grams of protein for ideal body weight. So it's very important. Protein intake 1.5, 25 to 30 kilocalories. Yeah, or like that. So to close on this, to conclude, what are some of the major interval route should always be preferred except for the following contraindication in terms of the interval route? Meaning there are conditions in which you might not prefer the interval route. When the patient is having intestinal obstruction and ileus, or severe shock in terms of septic shock and so on, intestinal ischemia, where meaning there is no blood supply to the intestine and then oxygen delivery to the intestine has a problem. So when the patient condition for which they're going for the surgery falls in any of this category, which has to do with high fistula, like in terms of the gut, and then severe intestinal hemorrhage, then of course you are not going to use the gut of that patient. You definitely going to settle for parenteral nutrition. So it is based on that that you will be able to now come up with your plan and how you are going to make your plan based on the condition this patient is going to be operating or for. So I think that's where we will come to the end of this. And thank you for your time. Rest is almost on the. Yeah, Milan, back to you.
Okay, thank you, Jesse, for that wonderful presentation. Yeah, I think it gives us a good summary of what we've been covering for the whole week. Uh, we have with us Martin from KNDI, Quality Assurance Department. He's a secretary for accreditation. Um, in the KNDI regulatory body. So it means we are here for serious business. Without wasting time, we have now a panel. Our panel is basically comprised of our two facilitators, who is Salome and and Okinda, and together with now our guest panelist, who is Jesse, just for us to be able to also just have an outside uh, feel of somebody who was not in the facilitation also being in the panel. Uh, I'll give Martin 1 minute so that he can be able to just say hi, so that we can be able to get the first group that is ready. Martin, are you here? Martin Kome?
Hi, good evening.
Good evening, Martin.
You're able to hear me?
Yes.
Yeah, thank you very much. My name is Martin, like Milan has said. I work with KNDI in the accreditation department, and I'm glad to join you this evening. And I hope that the sessions have been informative and have been insightful even for the practitioners. Thank you very much. I'll just be listening in the background.
Okay. Thank you, Martin Asante. Um, now, Okinda, which pair is coming first?
Good evening, Milan. Just allow me to share the pairs, so each pair knows which areas they are going to present on. Is the screen visible?
Yes.
So members, because of time factor, we can't have pairs going, but I know you've handled all the questions that were there. So we will give the first group to start. They will handle case study number 1. So the pairs which are ready, either Jacob Cephalus, Leah Brook, Mildred Naitore, Melody Muyula, Bettina Musia, Kevin Zachariah, Malvisha, Lillian Kasandi, Mary Wanjiku, and Achieng Okelo. So any pair that is ready, take it up. You are handling case study number 1. Case study number 2 will be handled just the same as you can see in your screen. So I hope you are taking note of your
No.
of the case study you are going to handle.
But we invited
Then case study number 3, we are going to have pairs from the last group. That is group 3. It is Faith Kungu, Daisy Muringo, Susan Onyango, Alice Njeru, Purity Maina, Lynn Nyambwa,
And
Lydia
also
Kimani,
his
Musita Caroline,
and the
and
office of
Caroline
his
Murungi
PS equivalent to his PS.
doing with Terry. I know there are other groups
Yes.
that some team members lacked pairs and they have worked as a group of either 4 or 3. It's still okay. The main thing is we discuss the case studies together and we move on. So group 1, the team that is ready.
But no, the
check
other
up
thing is, you
any
know,
group,
we've always
the
sometimes
team
just
that
said
is
we need
ready,
to
you
pay
can
courtesy
start
call, we
projecting
need to
on
engage,
case study number 1.
and also
You
the
can just
element
project
of
the whole case
just
study,
inviting them. But
the
you
whole
know,
case
sometimes
studies,
the
but you
opinion that you know the
specifically
politicians
emphasize on case study
they'll
number
come
1.
with their political
Thank
auras
you.
here, but no,
Milan, back to
it
you.
does not
I'm
matter.
stopping sharing so I can allow the team members to share from their side. The team representative. Team, is that okay? Is it okay with you? I need to
Yes,
get
it's
your...
okay.
Yes, okay. Yeah, so let's just do this. As we all agree, we are doing this for learning purposes. So, yes, I can see somebody, Faith, is trying to present. Okay, take it up now. The first group.
But yeah, but we should not hold certain positions like with those politicians. You know, the county has got both a political and administrative
Yes,
wing, because
which team
health
is
being
ready? We are
devolved,
having time. We'll
the
be taking
eyes
like
of the
10 minutes per
regulators
each
are basically
presentation
within the county
because at the
system.
end we are going to have a discussion and also the panel view on the questions.
mm,
So group one, kindly, don't take
mm,
much time. The group that is ready, kindly project your presentation.
mm, 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 mm. No, I understand. And also, you see, it is the county commissioner who invited Bongo, as we did have him in our program. Mm, I understand. I totally understand. I don't know what can be done. Maybe through the leadership, they can be able to maybe pay a courtesy call and say it was not the intention of the hospital to be able to invite Bongo. Bongo came on invitation of the county commissioner, and therefore we have nothing to do with that. Mm, mm,
Uh,
okay.
Anybody experiencing presentation challenges,
Mm,
projecting? You can
mm.
even as well share um, your
The amount.
presentation to my WhatsApp so I can be
Mm.
able to to project it for you, if that is still okay.
What was the issue?
Okay.
Yeah.
Oh,
Just share your presentation via my WhatsApp group. I'll be able to assist you
mm.
very fast.
Or the others, the colleagues now. I know, I know. Mm. One thing I can recommend, we saved something on the media. We Because I noticed they were rushing for the Njoka thing, so I noticed that they may be conflicted, and chances are, media house cannot play two news of theirs. Definitely, ukiwa reporter atachukua tu moja. So I noticed that you see right now also politics sell more than any other thing. So they'll not bother about all these other things. So I noticed that we will be wasting a lot of resources on them. So be niliwalipa tu thao tu brown envelope. So I think now something that we can be able to consider, maybe at management level, if that is a voted that you could
Okay.
consider consulting. Mm,
Okinda, if you can share
mm,
that
Yes, yes.
with me.
I've received yours. I'm doing that right away.
mm, 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 Who deals with them directly? I understand. I totally understand. Maybe next time we will be able to expand that budget. Yes.
So confirm it
Mm.
is okay from your end.
Yes. 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 Mm. Okay.
Are you able to see?
Yes.
Yes, yes.
Okay. Sir.
Okay, so I take it up from there. So you are starting exactly 6:42. 6:52 will you'll be done. We are timing. Thank you. Go ahead.
Okay, fine. Good evening, team. My name is Kevin Zakaria Wanyonyi. We had a discussion together with Bettina Mtinda and John Kandie. So the first question, Okinda, you can move
Yes.
the screen.
Yeah.
Uh, Case one, question one, they wanted metabolic risk factors to be considered for the above case. Uh, we thought
Maybe
of
Kevin.
age.
Kevin, just to cut you, maybe because of for the purposes of the our candidate panel and also our external team, maybe you just take us through the case study from the start.
Okay,
Yes, thank
okay,
you.
okay. The first case was a 72-year-old man with a history of changed bile habit, was found to have a sigmoid tumor. He has diabetes for which he takes oral medication and a mild hypertension. He is about 170 centimeters tall and weighs approximately 92 kilos. He says he is not fond of exercise at all and likes to watch television. He is very nervous about the fact he is having surgery. So the first question was, what metabolic risk factors should be considered uh, for this man? So we thought of age, having that uh, age adult above 40 years are more likely to is a risk factor for developing metabolic maybe issues. So we thought of 72 years as a factor, and then obesity. We found out that with a weight of 92 kg and a height of 172, BMI was in obese category. Then sedentary lifestyle, where from the history we are told the patient uh, the patient is not fond of exercise at all and likes to watch television. So in most cases, uh, nakaa sana, maybe they're afanyi a lot of exercise, so he's not burning extra calories. So we thought of those three metabolic risk factors. You can move to question 2.
So question 2.
Um,
Yes.
what preparations can be made to minimize the metabolic stress for him? Please explain. Uh, we uh, we agree that we need to ensure he does not starve for long periods by giving him a clear liquid diet 2 hours before the procedure, and then ensuring he takes his diabetic medication for his sugar levels to be stable, and then ensuring he is taking other medications as prescribed. And then question three, how can he best prepare metabolically for this procedure planned to start well after lunchtime? So we thought of giving the patient a clear liquid diet, which includes water, strained broth, and plain gelatin, as they are easily digestible and leave no residue. Then he is operated with sigmoid resection, including release of left flexure and an end-to-end anastomosis and no stoma. The operation lasted for 22 minutes. He was extubated in the operating room and was breathing well when moved to the high dependence unit. Lukinda? What parameters will be useful to control from metabolic point of view at this point and until the next day? So having he has a history, is on diabetic medication, so we thought it will be uh, significant to monitor blood sugar levels, then blood pressure levels, and the oxygen levels. Then question 5, if I can request Bettina to take it up from there.
Yes, Bettina, go ahead.
Good evening, everybody.
Good evening. We can hear you well.
So, question 5, when can this man be allowed to drink and to eat? So, considering that he had undergone a sigmoid resection, we thought that it would be easier for the patient to start with a clear diet after 24 to 72 hours, And if he tolerates that, then we could start him on a low fiber diet. And then he's found to have blood glucose of 12 millimoles per liter in the HDU. What could be the reasons for this, and what should you do about it? So, we found that when one undergoes surgery, both the procedure and the anesthesia they put stress on the body, and at times the stress can cause the release of stress hormones. When stress hormones are released, they can make the body less sensitive to insulin, and this can lead to elevated blood sugar levels. And because of this, people with diabetes have an especially high risk of high blood sugar complications after the surgery. And the next day, the nurse informs you that he's thirsty, but that his urine output is very low. She does not know exactly how much he has produced because they missed out on the measurements overnight. So, how much urine must he produce per hour? Why is this important? Can he be allowed to drink now? So the normal range of urine is 0.5 to 1.5 cc per kg per hour. And so we calculated using those ranges and found that the patient should be able to produce 48 to 138 cc per kg per hour. And it would be important to monitor urine production because it could be a good indicator of how the body is recovering from surgery. And also with the fact that we are starting this patient on a pure liquid diet, it would help us to calculate the fluid balance and to also assess his responsiveness to the fluid, so which helps us know how much the patient should get. And considering that he has diabetes, him not being able to produce enough urine could be signs of early kidney failure. And so us being able to monitor how much urine is producing, it could help us detect that and also start his treatment early. And yes, back to question number 6. There's a part that I thought
Um,
that you
but,
forgot to
but
include.
Bettina, your time is up. Okinda, the next group, I want them to start from critique of the first group. They can tell us what the first group did not get right, and then they can be able to tell us what they can include so that they don't have to present the whole thing again. Okinda?
Hello?
Yeah, leave the presentation on the show on the share screen. We want the second pair to critique what the first group has done. Tell us what
All
they did
right.
not get right,
So I
and
just leave the presentation
yes,
there. Yeah,
yes,
yeah, okay.
they can tell us what the first group did not get right, and
Yes.
then now they can tell us what they need to add that is different from what the first group has told us.
Yes. So this pair is still from under group 1, isn't it?
Yes, yes, yes.
Okay. So that is the group of Bettina, Musia, Kevin, and also who else? Who else? Who else? Just remind me, John. It's John Kind. Yes. So I would like to hear the critique from Mildred Naitore, Melody, and Achieng Okello. Can you kindly critique or add something on what they have presented? Actually, they have done a good job. Thank you very much for that. Let me just say that you've put more effort on it. So let me get the feedback from the other team members in group 1 to critique the case study. just to take you up on what the case study was, so you can be following and flowing. Kindly, because of time, let's make it faster. Yes, go ahead, Tim.
Should we just award that group a 0?
Um, Good evening.
Good evening.
It's Melody talking. Huh?
Yes, Melody.
Actually, I think most of the work that they have done, our work also goes hand in hand with it. Huh? But on question 4, on at what point, what considerations would I put until the next day? I'm looking at this person, most probably, as we are monitoring the blood glucose levels, how about we include parenteral feeding so that we don't also don't get to starve the patient for long after surgery, and looking at if we have to starve for long, then what about the sugars fluctuation and the stress that has been impacted due to the surgery?
Okay, Melody. Is there something that they have left out apart from parental nutrition? Is there something that they've left out that you think needs to be included in the plan of care in terms of the questions, how they were set on that particular case study?
Maybe I can give my input.
Okay.
The issue of carbohydrate loading, so that to avoid hypoglycemia, which was going to induce dyslipidemia.
Okay. Anything else?
That's the input I had.
Okay. Anything else? Mildred?
Hello.
Good evening, everyone. They have done a good presentation, and I think most of the points that we have in our presentation, they have covered them. I have nothing to critique.
Good evening. This is Mary Kamau. On question 2, what preparations can be made to minimize the metabolic stress for the patient? What I can add there is that the patient can be put on insulin so that to avoid hyperglycemia, since the patient is already a non-diabetic, putting the patient on insulin will reduce incidence of insulin resistance. Also, on what parameters, question 4, what parameters would be useful to control? I would take out for kidney function test and liver function test for the patient. Thank you.
Okay, so that is who spoke last? Kindly remind me.
Mary.
Oh, Mary. Okay. So Mary and Achieng have sorted us out. Have talked. Lena and Jacob.
Hello,
Yes.
can I speak?
Yes, we can hear you. Go ahead.
Yeah, okay, this is Lillian from Group 1 SEAL. I just want to first of all echo my colleagues who have just presented their case study. But okay, from my point of view, I have maybe a few additional points. From question 1, aside from what they have given us, the age, the weight, and the sedentary lifestyle, okay, my group also went an extra mile to factor in a few other metabolic risk factors that may affect our patient, of which we had an inclusive of insulin resistance due to loss of normal anabolic reactions. And then we had another point of chronic low-grade inflammation, which also mostly occurs in cancer and diabetic patients. So this could also be part of the risk factors that our patient could experience, supposing he's to undergo surgery. And then point number 2, I just have also a few additional points to add. Question number 2, which says, what preparations can be made to minimize the metabolic stress for the patient? So this entails mostly pre-operative stage, of which maybe we are not limited to time. So assuming we have received this patient a little bit earlier before the surgery, so our point to note or our concern will be to do a thorough nutrition therapy as early as possible. And this will help us to reduce the negative metabolic effects that the patient may experience later on after surgery. And then we also had a point of nutrition integration in the management of the patient. So this ensures that we have a proper balancing of dietary intake in terms of the carbohydrates and the proteins prior to the surgery. And this will help us by to reduce the loss of energy stores as a result of catabolism, which may occur during or after the surgery. And then another point to take is avoid prolonged periods of preoperative fasting. So immediately after operation, if our patient is responding well, we are to start enteral feeds as soon as possible. And then on another point of the parameters, question that is asking about what parameters will be useful. The point of parenteral and lab works just to check if the body organs are functioning well. I think also another point to add is adequate hydration with RL. RL is the Ringer's lactate, and the normal saline. This will also help us to prevent issues with the electrolyte imbalances, since after surgery, these patients are prone to experience such. So I think RL contains adequate amount of the electrolytes that you might need to stabilize the patient. And then if possible, continue with medication, since our patient is diabetic, we need to monitor the sugars and get back to medication and the hydration so that we can minimize issues of fever, which may tend to increase the catabolic rate of these patients. So aside from that,
No sound.
Hmm.
Hello.
It's the presenter.
Okay. So
Sorry, I lost network.
yeah,
Um,
just a moment,
okay.
Dokinda. So is there somebody from group one, the people who are supposed to present on the first case study, that have not asked a question, made a comment, contribution, or spoken?
Yes,
Who is
good
that?
evening all.
Yes, yes.
Jacob Lena Brooklyn.
Okay.
I think for additional for question one, the insulin resistance due to loss of normal anabolic action of insulin as result of the stress hormone. Then another point is increased catabolism, which is the breakdown of the skeletal muscles, protein, and transfer of amino acid to the wound in response to the surgical injury. Then additional for the question two, that is to start nutrition as early as possible to help to reduce negative metabolic effect the patient may be experienced. Another one is to avoid the prolonged period of preoperative fasting, as this may lead to breakdown of proteins and fats to provide energy to the body. Then question 3.
Milan, can you just confirm it is not only me who is breaking?
Jacob, kindly put your microphone closer to you.
Yeah, you are breaking, Jacob.
Network.
Yeah, I think you have issues with your network. We can't hear you very well.
Okay. Okinda, is there somebody else that we've left out?
Um,
No.
yes,
Can I add something?
Yes,
yes,
yes.
go ahead, Achieng.
For the metabolic risk factors in number one, for my group, myself and Mary, we found hyperglycemia, hypertension, and dyslipidemia. Then for number two, we said the preparations that can be made to minimize the metabolic stress was we do carbohydrate loading in order to avoid hypoglycemia, which was going to induce dyslipidemia.
Enda angalia mchele kama inakutosha kula mama kule. Ndio iangalie kama inatosha.
Nancy, please mute your mic. Then for question 3, we said that since the patient had no specific risk of aspiration, he can have free diets up to 2 hours before receiving anesthesia. And then we also recommended carbohydrate treatment before surgery to reduce postoperative insulin resistance and postoperative nausea and vomiting. And then the parameters that we would look at in number 4 is blood sugar, free fatty acid levels in the blood, and ketone levels in the blood. Then number 6, we said what could be the reasons for that? We said probably low urine output in postoperative patients, maybe due to poor perfusion of the kidneys due to heart failure or low circulating blood volume. We also said it could be due to either primary or secondary renal failure. It could also be due to structural damage or obstruction or poor function of the ureters, bladder, or urethra, and dehydration. If the patient does not receive adequate fluid, either oral or IV. And then finally, question 7 How much urine must he produce? We say that the normal urine output is 1 ml per kg per hour, so that is 92 ml per hour. So the patient needs to produce this amount of urine to maintain normal kidney functions. So we also recommend that the patient can start doing oral sips every 15 to 30 minutes. Thank you.
Okay. Okay, in the interest of time, I think we can move to the next group.
Yes, agreed. So, share. So the next group 2, which will handle case study number 2, will be Faith Rotich and Jane Mutuku, Jotham Mudhuri and Noreen Kigoshi. John Kahindias was in group 1 with Kevin, so it's good. Maris Guyo. We also have Lena Juguna and Christine Owino, Timina Wafula and Nancy Makoha. So which group is ready so I can project? I've seen you've sent me different presentations. So just say so I can know who is going to present next. Faith Rotich, are you ready? I can share your presentation.
Ready? Hello, yes,
Yes.
we are ready. Yes, we
Okay.
are ready.
So I've seen like 3 presentations from you. I don't know which one do you want me to present? Like 3.
The PowerPoint
The
presentation.
PowerPoint, okay? Okay.
Yes.
So let me just
Pascal. Ano link ini? Kini aku punya. Utiu kiki. How well can you hear away now? And you're a truly one rule.
somebody is presenting. Kindly stop your presentation so I can guide you. I know presenting from your phone is a little bit challenging, so that's why I have offered to support you. Just confirm the presentation is okay from your end and you can be able to see.
Yes, we can. I'm able to see.
So
Let's
let me
go
go to
down.
question 2, to case study
Yes,
number
please.
2.
Yes, please.
Yeah, there we go. So you take us from the beginning so we can understand the case study for those who are not there. Thank you. Go ahead.
Good evening, everyone.
Good evening.
Jen is my name. I'm doing a presentation we've prepared with Faith Rotich. A 45-year-old male comes to the outpatient clinic with a history of anemia and is found to have adenocarcinoma in the caecum. His staging CT scan demonstrates a T2 and OMO lesion. He is advised he requires a laparoscopic right hemicolectomy. So question number 1, what preoperative preparation relevant to enhanced recovery should he receive? So this patient has come to outpatient, so is not yet admitted. So is a patient we need at least to start preparing for admission. So the first thing, we prescribe an oral nutrition supplement that is before admission, just to ensure that by the time the patient is coming for admission, his nutrition is at par. And we agreed we can do Fresubin to kilocal, 200 meals 3 times a day, which will be able to give us at least 1,200 kilocalories per day. Then from the history, we learned that the patient is anemic. So we do a supplement of imatinics to ensure that we correct the anemia and also encourage foods which are rich in iron. We felt that we cannot be able to correct the anemia with only food from dietary alone, considering the time we might take for it to be well corrected. Then 2 to 3 days before surgery, we prescribe at least a low residue feed, and we change our oral nutrition supplement from to elemental feed like Nutricompeptide, which is low in residue. Then question number 2, When the patient attends for his pre-admission anesthetic visit, he asks if he should have an epidural or not, and why it might make any difference to his recovery. What would be your advice? We felt that an epidural will be an epidural anesthesia will be better, for this reduces risk of aspiration, regurgitation after surgery, and ensures that the patient recovers at a quicker rate. The next question, the patient has his operation and recovers well. What criteria would you use to decide when he can go home? And the first one is patient has good pain control with oral analgesics. The second thing is patient is taking solid food, bowel movement is established, and no intravenous fluids. And the last is patient is independently mobile. Then question number 5, why does ERAS propose a team to work together? And we felt that working together as a team helps the patient recover quickly. It reduces risk of complication, reduces healthcare cost by reducing hospital stay. And the last question was, what is the value of audit? And we felt that audit helps in determining if the protocols have been implemented, check on any incidences which might have happened, do root cause analysis of what might have happened and come up with corrective action. And this ensures that there's continuous quality improvement and care the patients. Thank you.
Thank you.
Thank you very much for that. Faith Rotich, that was a good one, and I'm so happy you stick within the timeline. So now I like still under group 2, Jotham, your team to critique or to add in the group presentation, Len Guna and Christine Owino, Timina Wafula and Nancy Makoha. Kindly give us your critique from this case study.
Kennedy.
Yes.
This is Noreen with, we did our case with Jordan.
Okay.
I would like to add a bit on the epidural.
Yes.
Why we advise the patient to also, she's done a very good presentation. The epidural also, we would advise the patient to have epidural because they'll have less pain and they'll become mobile much faster. And then also the patient may not be in need of insulin after surgery because the sugars will be better controlled if they have a epidural.
Okay, noted. Yes, another group. Your opinion, Nancy Makoha, your team.
Hey, Ken.
Hello.
Oh.
Yes, Purity, go ahead.
Okay, I concurred with the presentation, but the question number, hello, question number 2, I differed because I said it is not recommended because the epidural may lead to long-term complications such as permanent nerve damage, that is persistent numbness and tingling.
Okay, thank you. It's getting interesting now. Now at least we are having a discussion. That is Purity Minor. Okay, thank you.
Okay, Nancy
Yes.
Makoha with Timina.
Yes.
Yeah, on question number 6, I'd like to add
Just a moment, Nancy. Just a moment, Nancy. Before you get to question number 6, we want to hear your contribution on question number 3.
Yes. We are having conflicting answers, so we like to hear how did you handle question number 2. Yes, Nancy.
Kennedy,
Yes,
can
Christine.
I proceed?
Go ahead.
Yeah, well, presenting with Lena,
Okay.
our input is yes, it should receive the epidural because it helps in fast recovery, relieving the pain, and also it enhances intestinal motility. That's for question 2.
Okay.
Can I proceed with others?
So you
Yeah,
actually
yeah.
you actually agree with the Faith
The
Rotich
first,
team.
yes.
Why do you think that purity view, to the contrary, needs to be challenged or needs to be improved in a way?
I agree to disagree. On my view, it was, I agree with it. I'm not disagreeing with her.
Okay, but purity had a contrary view to the position that you share with Faith Rotich and Jen. So we need to convince her that this is the correct position and that has to be factual. This is open to the class so that we save time.
Yes, kindly feel free. Don't just wait for your group. If even in question 1, you can still critique because we are still having discussion. So you don't have to keep quiet. Yeah.
Okay, epidural is good
Yes.
because it takes less time
Okay.
for the patient to go back to normal, to normal feeding. Because with the general anesthesia, the patient takes a longer time because he has to start with the nil oral. Then with the light, with the liquid diet, then a light diet, you are like, it's a long process. But immediately the person comes out of epidural, you start feeding him orally immediately. You start with the fluids. So it is better than that, and it is also not it is contraindicated according to the books, like place we research with Timina. It's contraindicated. We shall advise that we go for epidural because of that.
Okay. It's getting interesting.
Okay, so I think
Hello.
yes.
Yes.
Hello? Hello?
Yes. Who is this?
Hello.
Yes, go
Timina.
ahead. Yes.
Yes, we also thought of because it also helps in management of post-op pain and also allows early ambulation. Yes.
Okay.
Okay. Okay, for us with the Noreen,
Yes.
okay, we saw that every procedure has disadvantage and the disadvantages. So we concurred with purity, whereby the epidural tube could damage nerves leading to permanent neurological deficit. But on the other hand,
Mm-hmm.
it has its advantages of good, enhanced recovery because of optimal gas. Hello?
Okay.
Hello? Hello?
Yes, yes. Go ahead. We can hear you.
Yes, so I think every procedure has its disadvantages and advantages. So we argued both.
Okay.
Yeah.
Anybody,
Yolanda.
yeah, anybody else with the contribution on this subject?
Yes,
Yes, proceed.
I'll consider epidural. Hello, can you hear me?
Yes, we can hear
Yes.
you. Go ahead.
I would consider epidural because it can be used to help to manage pain as used with local anesthesia. Epidural also can help to block sympathetic nerve afferent pathway to the GIT, so we are likely to reduce inflammation. It's also effective in promoting insulin sensitivity and may decrease
operative cytokine expression. So inflammation at the GIT will be much less. Thank you.
All right. So, team, I hope your findings and you've really understood how the case study was. And I'm so glad getting different answers. That is why learning is very important. So remember, this was a laparoscopic right hemicolectomy. So in every argument you are giving, laparoscopic should always be should be your guiding principle when it comes to epidural anesthesia. Anyway, let's move on. Other critiques?
There was a question number 6 critique by Nancy.
Okay. Yes, Nancy, you are critique question number 6. What is the value of audit? Nancy, was that the one?
Yeah.
Go ahead.
It ensures morbidity and mortality are minimized.
All right.
The value of audit, yeah. And also it provides feedback to the team to allow further development.
Wow, thank you. Okay. So is that an addition or you are trying to, you are adding something or you are trying to critique the answer?
I'm adding something.
Okay.
Yeah.
All right. Thank you. Team members, just give your opinion on this. It's not restricted to the group members only. We can have a discussion as we move forward. Any other thing you feel could have been added but was not captured in the presentation? Or any other question you might have concerning this? Yes. Damaris, go ahead.
Yeah, I don't know whether you can hear me clearly about my maths.
Yes, we can hear you, Damaris.
Yeah, but I think question 5,
Yes.
it also helps to reduce the psychological stress.
Okay, psychological stress.
Yeah.
That is why does ERAS propose a team to work together?
Yes.
Okay. Any other issue you would like to add, Damaris, pertaining the other questions? Is your group okay with the way they have given their answers?
Yes, but I think question the value of audit.
Yes.
I found it a bit challenging, but I have understood it. It's clear from the presentation.
Okay.
Yeah, thank you.
Okay, thank you.
Okinda, is there somebody in group 2 who has not spoken?
Ken?
Yes. Yes.
Yes, Lena.
Yes, Lena.
It's an additional for errors propose a team to work together.
Yes.
Okay, for the presentation with Christine, there was helps reduce preoperative stress and improve the by operative preparation and medication, fluid balance, anesthesia and post-operative analgesia, and then there is pre and post-operative nutrition and mobilization. Thank you.
Okay.
Yeah.
Thank you.
Hello?
Yes, Kevin.
Question 5. We also, from my team with Bettina and John, it also improves patient satisfaction and confidence in healthcare services. That's teamwork.
All right.
Kevin, would you go deep and tell us how?
I don't know if my team member can explain. Any member, if like.
Yeah.
Hi.
Okay.
Yes.
Okay. Welcome.
Hi. Go ahead.
Okay. At times you find that in the hospital, different
doctors, the nurses, the nutritionists, all of us are handling patients differently. We're giving them different information. We even end up confusing them. But handling one patient as a team will ensure that they have confidence in us, as my colleague has said, because we'll be speaking with one voice, meaning that whatever the doctor has said, we'll be able to know how it affects the patient nutritionally and where we're supposed to come in. And the nurses know what times and what sort of medicines they're supposed to give and at what range. Yes.
Yeah. Yes. So also, it also assures security because all of you as a team cannot be wrong. So if you're working together, even the patient feels some element of guarantee or some guarantee of security, which is a good thing. And this is a continuity of work because if a nutritionist would come and prescribe X, the doctor come and prescribes Y, just like what Jesse was saying earlier, and then now you don't know which of those two is correct. So I think that is something that is also worth noting. I think at this point we'll move to the next presentation. That is for group 3. Uh,
So,
Excuse me, Milan.
yes.
yes, go ahead, Milan. Jesse, welcome.
Yeah, because of time, I don't think we will come back again and then we'll be speaking on some of the issues that need to be addressed. Yeah, so that we save on time. I think just give me 2 minutes. 2 minutes.
Yes, go
And the
ahead.
2 minutes has started. On the issue of the epidural anesthesia is good. It's okay. It's not disputable that their importance should be underestimated. But the first thing is, when the patient comes in, you must first of all be able to understand the medical condition before you come in the nutrition. For me, I consider nutrition not to be an emergency. It's actually a supplementary part of the management of the patient, in as much as it is important. But there are so many ways in which our docket can be covered, even if there is no food. So you don't have to put too much weight on the nutrition when you have a specific case like that. That patient is anemic. That's the first thing must come into your mind. And a patient who is anemic, you find out like the heart rate of that patient will be low because of the issue of the reduced volume of the plasma level of the blood. The patient will be having low blood pressure, and the patient need to be transfused. Now, if you give that patient epidural, in as much as the patient needed, you find out like one of the major side effects of epidural is cardiovascular. It even lead to clotting. It even, in fact, bleeding is one of the major um, or side effect of it. And the patient is already anemic. When you bleeding and you have issue with cardiovascular, and any patient going to theater, that patient has to be prepared because have you ever wondered why is it that they are giving a patient fluid before you go to theater? It's because they want to beef up your blood pressure so that or through the process of you will not or suffer from bradycardia. Majority of the complication that arises from theater is low blood pressure. So with patient that is already anemic and they are even trying to transfuse before taking to theater epidural, you have to really think twice. Yeah.
Okay. Okinda, you can be able to present the next groups. Group
Hello.
3.
Can I ask a question?
Yes, yes,
Yes.
go ahead.
Okay, so my question goes back to Jesse. What I'm made to understand is that, okay, the type of the anesthesia to be administered will actually depend with the magnitude of the surgery. Or what factors are you going to consider so that you can decide if it's the epidural anesthesia or if it's the general anesthesia?
No, what happens? It is within it's within the docket of the anesthesia and the surgery. That's why You remember I was looking at the surgical area of a patient, and I told you the implication of the surgery that it has on a patient. In that case, I'm looking at the issue of the anemia, and there is no surgeon who will want to look at that. It has nothing to do with the magnitude of the surgery, whether it's taking 4, 5, or 6 hours. It's looking at the patient whom current state in terms of what are the complications that will arise if this patient was to have low blood pressure. Is this patient able to have something we refer to as is this patient system compensatory? Are they able to compensate for if there is a loss of blood? Remember, this patient is having a tumor, and they might go in to remove it, and that patient, no matter what happens, whether it's a minor surgery or major, that patient will bleed. You already having anemia, and they have to give the patient fluid to maintain the blood pressure. So giving somebody fluid who already is anemic, you already diluting the blood. So there's a lot of risk factor in that land. So you wouldn't want to um, kind of have you wouldn't want to give any room to any risk factor. So the surgeon and the anesthesiologist or whoever that is going to administer the anesthesia will be able to decide. But I can assure you, if that is the case of the patient, in fact, if talking about the epidural, they have different types of the anesthesia that they will give on that docket. So, but they wouldn't want to go that way because for most of these anesthesia have two major complications: cardiovascular and the issue that has to do with central nervous system. Yeah.
Okay, thanks, Jesse. Just team, just to close this discussion on the issue of epidural, and I said this one specifically to try to jog your mind for those who have interacted. And if you look at the case study was this patient was to undergo laparoscopic kind of a surgery, and most of the time laparoscopic type of surgeries are not normally invasive. They don't involve so much of cutting and also suturing because it is video guided, image guided kind of surgery. So pertaining this question, whether epidural could have been used, the answer is nowadays with laparoscopic surgeries, it is not necessary to use epidural for this case, for the cases. You can just use oral analgesia just for the pain. So it is not necessarily that you use the epidural because of the laparoscopic procedure that the patient is going to undergo. So you are allowed to give infusion of oral or IV kind of painkillers that will be able to sort and help the patient to cope through the surgery. So again, as Jesse has also mentioned, to issues to do with the anemia and also the effect that epidural surgery will have to this patient, especially the hypotension. I hope that is well understood. All right.
That is a another day.
Yeah. Okay. So remember, we'll present the findings after we are through. That's why I feel time is of essence for us to continue very fast so we can have discussions as we move on. Group 3, Faith Kinywa, if you are ready. So group 3 is Faith Kunu and Daisy Muringo, Susan Onyango, Alice Njeru, Purity Maina, Lynn Nyabwa, Lydia Kimani, Musita Caroline, Caroline Murugi Dwiga, and Terry Achola. So you are in group 3. So I've started the presentation with Daisy. So Daisy, you are good to go. Let's discuss question 3. Case study number 3. Case study number 2. There we go. Are you able to see the screen, Daisy, from your end?
Yes.
Sure. Go ahead and discuss it. Yes, Daisy, go ahead.
Yes, hello.
Yes, we can hear
Um,
you.
I will start. So let me read the question. A 58-year-old female presents. I hope you can hear me clearly.
Yes, we can hear you clearly.
A
Yes.
58-year-old female presents with a recurrent abdominal complaints and irregular bowel movements after 2 previous episodes of diverticulitis sigmoid. The last time, 3 months ago, endoscopy showed that endoscopy showed sigmoid stenosis. The histology showed no cancer. So question 1 is an indication for surgery. From our discussion, we said yes. Reason being, sigmoid stenosis is caused by chronic diverticulitis. If you can see from the question, the patient developed irregular bowel movements after 2 previous episodes of diverticulitis. So it ended up becoming chronic, and now the patient developed sigmoid stenosis, which can only be corrected through surgery. So sigmoid stenosis, which is caused by chronic diverticulitis, it's an inflammation that causes fibrosis, obstruction of the colonic lumen, and it changes the bowel habits, and that is why the patient had complaints and irregular bowel movements. So the treatment is surgery, and the answer is yes. I proceed. The nutrition status: no weight loss, no reduced food intake, and the weight of that patient was 75 kgs and a height of 165 centimeters. And the patient, she had a BMI of 27.5 kilograms per meter squared, which is higher because above 35 kilograms per meter squared. So this patient's nutrition status is considered overweight. But there was no history of diabetes, no hypertension, no cardiovascular or pulmonary risks. Am I allowed to proceed?
Go ahead. Yes.
So the question 2 is the patient at risk. And you said yes, and I believe the question was about is the patient at risk of the metabolic, uh, what am I saying? I mean, is the patient at a risk of metabolic risk factors, which are diabetes, hypertension? So it is yes, because number 1, the patient is overweight. So when she is overweight with a BMI of 27.5, which is higher than 25, that means that she's at a risk of metabolic factors, for example, like diabetes and hypertension, and also the cardiovascular issues. Question 3, do you consider the patient for an ERAS protocol? We say yes, because from the first very question that I answered, we said that sigmoid uh, stenosis can only be corrected by surgery. So ERAS protocol will be important. ERAS is an enhanced recovery after surgery, the full term of ERAS in the abbreviation. It's usually a patient-centered multidisciplinary team that develops pathways for surgical specialty. So it is used to help the patients reduce surgical stress response, and also it helps them facilitate recovery. So for this patient who is supposed to undergo a surgery, is qualified. It's considered to. The English is going.
Where? All right, continue.
Oral protocol is yes. So the answer for our discussion was yes. It is important
Yes.
because the patient is definitely supposed to be undergoing surgery. And then question number 4. Preoperative conditioning.
Mama nakusoma nini? Madam.
So preoperative conditioning right here is
Hajajibu.
I mean very important for the patient. We have
Hii
we
wiki
had the options.
nafikia
A
kwa sababu hizo vitu za board
was
zimempeleka mbio.
carbohydrate loading, B immune nutrition, C both, D no. So our answer was carbohydrate loading. Carbohydrate loading here in surgery,
Kwa chapel.
preoperative, carbohydrate loading drinks 2 hours before surgery. It's usually very effective for patients that helps to attenuate insulin resistance. And also it minimizes protein
Huko kwa
losses.
kitchen.
And it also helps improve patients' comfort
Sikuna hiyo
without affecting
mahali
gastric
tulikutana na
emptying
watu wa
and
CPMH
also
ile siku.
reducing the hospital stay of the patient. And then question number 5 is boil preparation
Junctions huwezi pata.
important in this case? The question
Madaktari.
is yes, still.
Okay,
Boil
can ask in the morning.
preparation before surgery is usually very
Just say there'll
important.
be a meeting,
And that
venue
is
will be
why
communicated in the morning.
we have clear liquids that are usually used before surgery, like juices or black tea that
Hebu
is
nipike
sugar free. It is done, boil preparation before surgery is usually done to make sure that there will be no problems, I believe, from infections that may occur or rather reduce the risk of injuries
Yes, Baba.
during surgery. So boil preparation at this point
I'm almost through, Baba.
supposed to be
I'm coming
considered,
by
highly
exactly
considered.
8. I'll be in the house.
Am I allowed to allow my partner to continue?
Yes, yes, yes.
So my partner is Faith Kongo.
Hey.
Yes, Faith. Kungu. Take it up. Faith Kungu, you can hear us. It's your time.
Yes, I can hear you.
Sure. Go ahead.
The other question was about surgery as laparoscopic immunization with stapler at. I can't see it clearly. Please enlarge it. I can just see the question: which option is important Ehlers module?
You can see it now. Let me just bold it up for you. Hope you can see it now.
Surgery. Yeah, question number 6. The option is an important Ehlers module. And we discussed and we say epidural anesthesia. Reason being this possibly will be an open surgery and epidural will be part of management for pain, post-operative. We have the effect of insulin sensitivity. As we had discussed, epidural aspirin can help with blocking sympathetic nerve innervation, which leads to inflammation of the gut. So the answer will be epidural anesthesia. Can we go ahead? Question number 7.
Yes, it is there.
Which option is important in a last module? We said the answer is, I'll say a few hours after surgery.
That is what you've chosen as a group.
Yes. I don't know how it was not ticked.
Okay.
A few hours
Oh, I'm
after.
sorry, I forgot to highlight that one. I think typing error. Sorry.
No problem. We've sorted you out.
Yeah, that is the answer to number 7.
Okay. Might you be able to expand?
We don't want to delay feeding because few hours after surgery, once the patient is awake, we can do clear fluids. As the patient tolerate the feeds, then we introduce other meals. But at least we give few hours and the patient is awake, then we start clear fluids.
Okay. So which next? Okay. So the next question is question 8. I hope you can see it.
Does the patient need nutritional support? I'll say yes. Can you go slightly higher? I see the previous one. Okay, it's okay. Go down.
Sorry, your slides are keep moving. Okay, but let me see. This one. So I go to the previous one. Now
No,
question.
it's okay. Just go to the one for the support.
Okay. Does the patient need nutritional support? You've said yes.
Yes.
So yes, go ahead.
We discussed it as being a GI problem, that stenosis. After the surgery, maybe we'll need to give more time for healing. So we thought of nutrition support will help at least to give the required energy, as in caloric, nutrition, energy dense food. Maybe if we use something like bean to substitute for, because we don't want to give high fiber diet and the rest, maybe for nutrition support we can do that clear liquid food that have high fiber. At least we don't need a lot of digestion to disrupt the incision site. So that was our discussion.
Okay.
So after an uneventful course with peristalsis and more bowel movement, the patient present with vomiting and abnormal distension on post-operative day 4, white blood cells of 15,000, CRP of 230, CT scan, anastomotic leakage. Open surgery, dissection of the anastomosis, new anastomosis of descending to the rectum, deviating colonostomy, postoperative care in ICU, intraop central venous line, low dose catecholamine on elective ventilation. Please go to the other Nini. Enlarge on that question. Does the patient?
I'm trying.
Okay, does the patient need nutrition support? On this one, I'll say yes, because we can't feed orally after failure. Like this time we have leakage. So I'll say like the surgery, there was complication after surgery. So nutrition support, I'll say completely yes. And this time it will be adequate, I'll say on day 1. And we avoid enteral and oral, so I'll go for fully parenteral feeding. I think I've answered the 3 questions together. Yes, we need nutrition support. Day 1, we don't have to rate, but we go for parental feeding because enteral and oral is contraindicated after complication, that's the leakage.
Question 12.
Do you consider parenteral glutamine supplement for the patient? Yes. We can use parenteral glutamine as a method of nutrition support. It will enhance healing, being we said glutamine is a building block for protein and other metabolic effects. So glutamine will be effective for management and helping to quicken up the healing process and maybe reduce the stay at hospital and the cost. 13, do you consider lipid emulsion containing omega-3 FA an appropriate choice for the patient? I'll say yes, and I request Daisy to help me on that.
Yes, Daisy.
Anyone from the group, please help me on omega-3.